We're going to have more questions on that, but let me just bring in Dr. Luke Evans.
Thank you, Chair. I'm going to work my way down the panel because it's almost set up in the referral pathway that I can see. So, Dr. Roop, starting from that, we heard provisionally in the evidence about Jessica, and something that struck a chord with me was seeing someone for the third time and making a decision there. Do you think GPs are alert enough to seeing repeat symptoms and making a different decision?
I think we all need to revisit what we learnt at medical school, the old mantra of 3 strikes and you're in. So if a patient presents for the third time with the same symptoms and you're no further forward in the diagnosis, you then really need to sort of call in the cavalry and send them to your secondary care colleagues for diagnostics. And I think that may have been lost. There is certainly a perception that there is a pressure not to refer.
You've hit the nail on the head. How much of a reality do you think that is? There are scarce resources, there is scarce time. You're absolutely right. Often when secondary colleagues used to say to me, why are the GPs always referring patients in? We say, well, actually, it's much harder. You'll spend 45 minutes on the phone trying to get someone in. Actually, you feel the pressure not to do so. How do you think that balance has changed over the last 5 years?
I think actually one of the perhaps silver linings of COVID is that it has allowed and it has become essential to work collaboratively with our secondary care colleagues. In our patch down in South Hampshire, we have a very robust advice and guidance service. And certainly if you look at one of the reasons why perhaps we're slower in diagnosing is we've lost the ability for GPs to pick up a phone and speak to a secondary care colleague. We know that in Sweden, where they get much better outcomes, they still have that open phone line. And I think we need to restore that as best we can so that we GPs, when we have uncertainty, we're looking for a steer, we can talk to an expert in the area that we're concerned about. And in terms of where there are non-site specific symptoms, the rapid investigation services, the rapid diagnostic centres are just one such area where we could get that advice.
Do you think the UK's got the model wrong in this sense? GPs do a great job as gatekeepers. However, we heard that in Jessica's case, they ended up going privately to go to an ENT specialist for a problem. There are many, where I've worked, we have Polish patients, and they're often very keen to come in and immediately say, why can't I see an endocrinologist or an obs and gynae person, because I just self-refer to them. Is there something in that we should be looking at? You've hinted at the rapid diagnosis, but that would, I assume, would still be a referral by GP. So is there something that a patient base could go, I've got a red flag symptom, should I self-refer directly to a unit?
Yeah, and interestingly, in Wessex, we are exploring a model, a pilot of having breast symptom direct patient referrals, so they can make their own referrals into the service. So we're doing a pilot on that. I think the gatekeeper role has its strengths and its weaknesses. We heard earlier about continuity of care. If you didn't have that gatekeeper role, there would be no continuity of care. And certainly if you look at our French colleagues, and we've got friends who live in France, they can go from one specialist to another. And of course, that requires the patient to know which specialist to go to. That in itself can be a challenge for us GPs, because the whole system is set up that we need to know who to refer to before we've reached the diagnosis. And it's that the development of the rapid investigation services, the rapid diagnostic centres, for once is actually looking through the telescope from the primary care end, in that we need symptomologists rather than the urologist or the gynecologist, because we may not know who to refer to because we don't yet have the diagnosis.
And to flip it on its head, many doctors practice and tell me they're worried about being sued, about missing a diagnosis. Mm-hmm. How much do you think that contributes to people referring on for the 55-year-old with 2 weeks of not being able to swallow properly, or a little bit of tummy upset and acid reflux leads to saying, well, this could be cancer at worst case. And so referring as a protective mechanism to make sure that you don't miss the cancer case. How much do you think this plays a part in our system?
I think there's always an element there. I think the data suggests that each GP will exercise their indemnity policy once every 10 years. So that's the defensive medicine aspect is always there. But I think GPs are trained professionals. We pick up on signs and we do the best we can. If you look at the system that we have at the moment, there's a a nice guidance called NG12, and that sets, it's a very numbers-based thing, it sets at a 3% threshold, where the risk of cancer is 3%, you then make a referral. But of course that means that if the risk of that patient having cancer is less than 3%, there really is no pathway for that person. And when you change that into a fraction, that means basically 1 in 30 patients we're not making a referral on in that first instance.
And we're expecting more advanced cancers being presented due to the pandemic. There was often in my practice, you get them once every 2 months, the person you go, this is a barn door cancer. Yet they still go in the 2-week wait. And someone else might come in who will say, well, you're not sure, but they go on the 2-week wait. Is there an argument to have an immediate, for those who, this is a definite nailed on cancer that this person needs picking up yesterday? Is there an argument to have a system within the system to pick up those definite cancers?
Yeah, and very often that you can exercise that by calling a colleague. So I had a patient a few years ago who I was really worried. I spoke to the consultant and they said they can't wait 2 weeks, send them straight in. And again, if you've got those lines of communication that are straightforward and you're not hanging on the line for 45 minutes at the hospital switchboard, then that would lend itself to that.
Should the NHS be looking for?
Can I just encourage you to go down the
Yes, I'm sorry. I've
got some other colleagues.
Yeah.
I was just wondering whether, Doctor, you might, or the college might just write to us, if you haven't already, with any changes you think we need to have to the cancer referral pathway with respect to general practice, because I think this is the heart of the discussion that you're having with Dr. Evans.
Yes, it leads me very quickly on to this one. You mentioned AI in use of dealing with identifying. How does AI help actually when you're reading the scans, Dr. Dickinson? I mean, is there a pickup that we could be using to make sure that you're not missing, within the internal side of radiology itself, so almost as an aid to make sure that actually this area looks a bit shadowy, I'm not sure about this part on the CT or MRI scan?
That is where AI is being placed at the moment. Unfortunately, as yet, there are there's no good evidence that works in real time. So the most recent article in the BMJ last week said breast cancer, looking at, rather than going from 2 doctors reading mammograms to 1 doctor and 1 computer, in trials it looks really good, but in real life it's not as good as 2 doctors, so you're then missing. There is some nodule follow-up, so you pick up nodules in lungs. That's very good for helping see if there's a nodule, but using AI as a triage tool is not yet
it's not there yet.
No, it's not there yet.
In a practical day-to-day sense, how would you assess the NHS in terms of its IT ability for you to get your scan to the GP and vice versa?
Generally very poor. I mean, most places you can't. I work in one centre and deal with patients in another centre. I'm an oncologist by trade, so I go out to the local hospitals as Jess was in a local hospital. You go out, you meet your patient there, you see the scans there. They're not visible when you come back to your base hospital. You have to actively push and pull them there. You can't visualise them. Scotland has a whole networked PACS system within the country, so you can look at the scans wherever you are in Scotland. So it is easy to do. It just requires the will to do it. So
can you give me a figure? 10% of your workload, 5% of your workload, chasing IT admin.
At least 10. On a bad day, 20.
Taruk, percentage? Your work?
Luke, I'm going to have to move on to some other colleagues. Sorry, it's very
but
important.
I could just get an answer to that question,
by all means.
And also just Dr. Miller, one word answer on the percentage.
Okay, sorry, it's just been
about 10%.
Yeah,
10%.
About 10-20%.
Yeah, I think that's the point I wanted to get across.
Very important one. Very important one. Paul Brisson.
Thank you.